Hello, everybody. Rob Mordkin, the Chief Medical Officer for Let's Get Checked. Happy to be joined by Dr. Marc Cornier, who is on the webinar with us today. Marc, welcome, and perhaps you can intro yourself and tell us a little about your background and your area of specialty.
Sure. So I'm an endocrinologist by training. I'm at the University of Colorado in the Denver, Colorado area, and I've done general endocrinology for well over 20 years in different capacities, county hospital, university hospitals, community hospitals. I've also done quite a bit of focus on metabolic disorders like diabetes and obesity, lipid disorders. But I do research, I teach, and do some administrative duties as well.
Great. Well, thank you. We appreciate you helping us out with this webinar series where we're really aiming to connect experts within their medical field to the population and our customers to try to provide more information and education where we can. And certainly thank you as well for your contributions to Let's Get Checked as an advisory board member. So with that said, we have tried to put together some popular questions that we hear at Let's Get Checked about the endocrine system and the conditions around it, and we'll try to walk through them. So maybe as a starting point, as a real basic question, if you could define for us, what is the endocrine system, what is a hormone, and how does that all play into somebody's human body?
Right, that's a great place to start. So the endocrine system is a complex network of endocrine glands, that's what we call them, and these are glands that produce a hormone. Some of these glands you might know of: the thyroid gland, the pituitary gland, the adrenal gland, the pancreas, the testis in men, ovaries in women. But there are other glands. Fat tissue is an endocrine gland. It makes a hormone called leptin. The intestinal tract is an endocrine gland that makes a number of hormones that impact insulin metabolism and food intake. So there are many endocrine glands, and they talk to each other. So what a gland is that it's an organ in the body that makes a hormone. What is a hormone? It's a substance, a protein that goes from one part of the body and communicates information to another part of the body. So for example, thyroid hormone is produced by the thyroid gland, but then it goes all over the body to tell the body to do different things, whether it's normal cognitive function, your muscles to work properly, your metabolism to work properly. Some hormones go to other endocrine glands and tell those glands to work properly. For example, the pituitary gland makes a hormone called ACTH that tells your adrenal glands to make a hormone called cortisol. So it is quite complex. This system is based on feedback loops, meaning if a hormone is not enough of a hormone is made, another hormone is increased to tell the next gland to make more. So it's a pretty complex system, but it works very, very well for the most part.
That's great. Yeah, obviously really complex and complicated. Now I understand why you have such a tough and important job. Glad there's experts out there about this. So one of the panels that as you know, we offer through Let's Get Checked, and we have quite a number of people that come to us seeking this blood test, lab test, is around thyroid function testing. So maybe you could talk a little bit about, when we do thyroid testing, what is it we're actually testing? What perhaps are some of the common thyroid disorders and symptoms that one might look through, and are these treatable conditions? I know there's a lot in that question, but if we could talk a little bit about that, that would be great.
Absolutely. So let's just start real quickly. The thyroid is a gland. It's shaped like a butterfly. It sits in your neck right here. It's one of the few endocrine glands you can actually feel on a physical exam. And it makes a hormone called thyroid hormone. There's two types, one that's called T4, one that's called T3. And they're very important for normal function of your body as a whole. The disorders that we see with thyroid disease are one of functional problems, so either too much or too little thyroid hormone, but we also have disorders of the thyroid that relate to growths on the thyroid, so nodules, goiters, which are an enlargement of the thyroid thyroid cancer. So these are a separate entity. So really the one that people are talk most about are functional issues. And the one that's the most common is hypothyroidism, which is not enough thyroid hormone being produced by the thyroid gland. Now, thyroid hormone, as I said, goes to every organ in the body and tells different organs to do different things. And so you can imagine that the symptoms of low thyroid can be all over the place. It could be feeling tired. It could be not thinking clearly. It could be constipation. Could be feeling cold. Could be dry skin. So it's not specific at all. And that makes it a little challenging to diagnose. When we are looking to see if the body is making thyroid hormone normally, we actually don't test thyroid hormone itself usually. We start with a test called the thyroid stimulating hormone, or TSH. That hormone is actually made by the pituitary gland. Pituitary gland's in the brain, and right smack in the middle of the brain. And the pituitary makes TSH, which then tells the thyroid to make more or less thyroid hormone. So when there's not enough thyroid hormone circulating in your blood and your body, the pituitary gland senses that and makes more TSH. So the diagnosis of hypothyroidism is made when the TSH is actually elevated. So that gets confusing. So the test is high, yet that means low thyroid hormone. And then the opposite happens. If there's too much thyroid hormone being produced by your body, or let's say you're on a thyroid hormone treatment and you're taking too much of it, the pituitary gland in the brain again senses that there's too much thyroid hormone around and it shuts down. So then the TSH goes low. So again, opposite. But again, the best screening test is the TSH, because the first thing that changes is this TSH test.
I see, and obviously that's one that we are able to assay through our testing capabilities. I'm wondering, are there? You mentioned that there can be some fairly vague symptoms that one might present with that would start, you thinking about should you be looking at your thyroid and looking at TSH testing. I mean, are there really common ones with both of those conditions, the two extremes, if you will, the hyperthyroid group and the hypothyroid group? Are there common themes that would very typically define one or the other?
Absolutely. So symptoms that would be common to both would be fatigue. With hypothyroidism, it's because the body slows down. Hyperthyroidism, your metabolism is revved up, so you're tired from that and not sleeping properly. Another would be hair loss. It's common to lose hair when you're sick, and with hypo and hyperthyroidism, we see hair loss. In women, changes in their menstrual cycles is a common finding in both hyper and hypothyroidism. With hypo, you often see heavy periods early. With hyperthyroidism, lighter periods, but ultimately the periods go away completely with both hypo and hyperthyroidism.
Hmm.
Those are the symptoms that are most likely to be common. Now, what's common, hypothyroidism being the more common thing, the symptoms that are most common out there are feeling cold, feeling tired, feeling, dry skin, like hair loss, as I mentioned. Constipation is another one. Again, you can get all those symptoms from other things. So just because you have one of those doesn't mean you have hypothyroidism. But the more of those symptoms you have grouped together, the more likely you are to have hypothyroidism.
And it seems like without oversimplifying it, with by just doing basically the simple the simple assay for thyroid function and specifically the TSH, you can rule in or rule that out pretty quickly, right? So it's not a big diagnostic lift generally to take a look and have somebody figure out if this is a diagnosis they need to be concerned about.
Absolutely. The TSH test is a very sensitive way to pick up both hyper and hypothyroidism, and it's extraordinarily rare for the TSH test to not be accurate in that sense. Now, there are rare conditions. For example, if your pituitary gland isn't working, we call that central hypothyroidism, the TSH won't be elevated, but that's very, very rare. The
Got it.
other thing, though, is as you do tests like these, there's a common supplement that impacts our thyroid function tests in the blood. It's called biotin. Many people take biotin for hair and nail health. Biotin impacts the test. It doesn't impact thyroid function. It just impacts the test in the test tube. And so we recommend people to not be taking biotin for at least 5 to 7 days before they do testing. But other than that, the tests are very accurate and give you a good sense of what's happening and going on.
That's great news or great information. And I think the other thing that's probably important to drive home here is that uh, the bright spot in all this is that if somebody were to be diagnosed with either of the thyroid conditions you just mentioned, either the hyperthyroid, where there's too much thyroid floating around in the blood, or the hypothyroid, the other end of the spectrum, both are, as you say, diagnosable, but perhaps even more importantly, they're very treatable as well. Is that a true statement?
That is correct. And that's one of the reasons why I went into endocrinology, because you find a problem, too much or too little of a hormone, and you can fix it. There are many health problems where you can't fix them. So I was very excited about that when I went into this field. And yes, thyroid hormone replacement for hypothyroidism is very well tolerated. We use a hormone replacement therapy that's identical to the hormones your body makes normally. And the vast majority of people do very well with their treatment. With hyperthyroidism, it's a little more complicated, and that probably needs to get referred to an endocrinologist. There are medications that can block thyroid hormone production. There are other treatments like radioactive iodine therapy and surgery that can be used as well.
And is it fair to say as well that once somebody were to get diagnosed with one of these conditions, move into treatment, particularly if it's a medication treatment or to replace hormone levels, that further monitoring and testing is going to be important to that, to make sure that whatever treatment they're getting is effective, and that dose adjustments on medications don't need to be implemented as well?
Absolutely. So, we can have a general sense of what a dose of thyroid replacement should be for a person based on their size, but it really requires testing to get to the right levels. I mean, when we treat someone, we want them to feel better, but we also want to get the blood levels into a range that we would consider be normal. And that range may be different depending on your condition, your age, but certainly the testing is very important.
Good to know. And I assume that those ranges, even if you get somebody into sort of the target range that you're trying to get them to, as you say, I mean, age impacts that, but other environmental things might impact that. So continued monitoring is going to be important going forward, as they may need dose adjustments over time.
Absolutely. If you gain a bunch of weight, you're going to need a bigger dose. If you go on a medication that potentially blocks the absorption of thyroid hormone, like iron replacement, for example, you may need more thyroid hormone. Or if you lose a lot of weight, maybe now you need a less of a dose. So it's very important to be monitored on a regular basis.
Well, great. Thank you for all that information. I'm sure we could go on and on about this, and I hope to someday. But the next topic is probably one that will need its own series in and of itself. So I'm just going to dive in. I want to talk a little bit about diabetes. It's probably not even fair to say talk a little bit about it. Diabetes, I know, is an incredibly common condition worldwide, certainly here in the United States. And wondering if you could talk a little bit about prevalence, and again, back to, how does somebody perhaps be concerned they may have it? What does that look like? And we can go from there.
Right. Well, diabetes, again, we're referring to a disease called diabetes mellitus because there's a different kind of diabetes, insipidus. Diabetes mellitus is a blood glucose or blood sugar disease. It means that you have high levels of glucose or sugar in your bloodstream. That sugar should be in your cells. Your cells need sugar as a fuel or energy source. And diabetes happens when you can't get the sugar pushed from your blood into your cells. It's either due to lack of the hormone insulin. Insulin is the key to the door to get sugar into a cell. So it's either you don't have enough insulin or no insulin, or you have insulin that doesn't work properly. Diabetes is extremely common. In the United States, the data are there are over 30 million people in our population who have diabetes. 95% of that is type 2 diabetes, and I can get into that a little bit more. So that's about over 10% of our adult population has diabetes, and that continues to grow significantly. Some of this is due to the increase in obesity that we've seen over the last number of decades, and obesity being a primary risk factor for development of type 2 diabetes. But we've also seen an increase in the incidence of type 1 diabetes over the last number of years. And so both types are more prevalent. Some of it, I think, is there's more awareness in the diagnosis of type 1. We were misdiagnosing people as type 2 before. So again, type 1, yes.
Sort of give sort of a very general breakdown of how you make that distinction between a type 1 diabetic and a type 2 diabetic?
Right. So in type 1 diabetes is a disease that's caused by an antibody reaction. So your immune system basically produces antibodies that attack your pancreas and the cells that make insulin. So basically destroys those cells and you're left without the ability to make any insulin. So it's a disorder of insulin deficiency. But it's an autoimmune disease and often can be associated with other autoimmune diseases. Often it starts in childhood. We see it occur in infants to toddlers to teenagers. But I've made the diagnosis of type 1 diabetes in a 75-year-old individual. So it can happen at any time. It used to be called juvenile diabetes, but it's type 1 diabetes is the right name for it. And again, this is an autoimmune disease that requires insulin therapy for treatment. Type 2 diabetes is a disorder that starts with insulin resistance, meaning your insulin in your body doesn't work properly. Eventually, you just can't make enough insulin to keep up, and then you get high glucose or sugar in your bloodstream. This is a very much genetically determined. You have the genetic risk in the right environment with excess body weight and body fat and obesity leading to that diagnosis. Many people can be treated for type 2 diabetes with medications that are oral agents or other injectable therapies, but many patients with type 2 diabetes also need insulin therapy. Type 2 diabetes is treated with weight loss, and bariatric surgery is hands down the best treatment for type 2 diabetes and is often associated with resolution of the disease. So you can reverse it, whereas with type 1 you cannot.
And why should somebody be concerned about it? In other words, all right, so you have high blood sugar, maybe you are a type 2 diabetic and you didn't know it. Why does it matter?
Right.
What symptoms would they have, and what's the impact of that?
Well, first, when the blood sugar gets high enough, people don't feel well. There's the the acute symptoms of high glucose or hyperglycemia is what we would call it. So you start losing sugar in the urine, and that draws water with it, so excessive urination. Then you get dehydrated, so then you get thirsty, so excessive thirst. That sugar is in the blood instead of in your cells, so you start feeling tired because you're basically starving, and you start losing weight. Sugar gets in the lens of the eye and changes the shape, so that causes blurred vision. So people just don't feel good and have all those symptoms when the sugar gets high enough. The hope is that you actually find that diagnosis before those symptoms occur, and that's why routine screening of high-risk individuals is indicated for people. But the reason we care is, one is people don't feel good, so we want to get their blood sugar treated so that they feel better. But long-term, high levels of sugar in the blood leads to significant damage of multiple organs in the body. So nerves, a condition called neuropathy; in the eyes, a condition called retinopathy; and then the kidneys, called nephropathy, so the leading causes of blindness, kidney failure, amputations is due to diabetes. But also very much important is the increased risk for cardiovascular disease with type 2 diabetes and type 1 diabetes. So those are the reasons we want to treat people long term, even if their levels aren't high enough to cause symptoms.
Got it. So, I mean, in really layman's terms, a much higher incidence of heart attack or stroke in somebody who's a diabetic, particularly somebody who is a poorly controlled diabetic, meaning that they're not doing a good job of maintaining their blood sugars, as you said. And bringing it down to, sort of what we can offer at Let's Get Checked. I mean, I think we certainly have the ability to do lab tests, obviously. What kind of lab testing surrounds sort of the diagnosis or the ability to look for diabetes? Where would we land on that?
Well, there's a number of tests that are recommended by organizations like the American Diabetes Association. The most commonly done test is called the hemoglobin A1C, or the A1C test. This gives you a snapshot of what your blood sugar is over the past 3 months. So hemoglobin is in your red blood cells. Red blood cells live for 3 months. That hemoglobin molecule gets altered by sugar, so we can measure that. So the A1C test has been adopted now for a number of years as a good screening test. You don't have to be fasting for it. And there are specific cutoffs that have been determined by, excellent research to say that if your A1C test is 5.7 or higher, that's pre-diabetes. If it's 6.5 or higher, that's considered diabetes. Now, there are some other disorders that can impact the A1C, so you do have to be a little careful. If you have a disorder of red blood cells that make them live longer or live less long, that's going to alter the A1C. But in general, it's a very good screening test, and it's nice because you don't have to be fasting. The other tests require a blood test of the glucose, the actual sugar level in the bloodstream. That requires fasting for good screening, either a simple fasting glucose or a glucose test after you've consumed a sugar water substance and you measure the sugar level 2 hours later.
And much like we were talking about looking at thyroid disorders, I assume the same applies here in the diabetes discussion, where if somebody gets a diagnosis, there are certainly various ways to go about treating, whether it be for behavior modifications that you mentioned earlier, weight loss and diet changes, medications maybe. But I suspect that once the diagnosis is made, further testing over time is going to be very important as well to make sure that the impact of the treatment is it being achieved.
That's correct. So it's usually recommended that a test like the A1C is measured about every 3 months to determine how your control has been during that time. And based on that, we alter our treatment plan. Now, you can also monitor your sugar level on a day-to-day, hour-to-hour basis with, finger sticks using glucometers or with continuous glucose monitors, which can be very important for especially patients with type 1 diabetes. But the A1C test is the standard and should be done on a regular basis to make sure that you're at goal, and if you're not, that your treatment plan is altered.
Terrific. That's great information. Thank you. All right,
And then let me just say one more thing. Like with thyroid disease, very well treated. So with type 1 diabetes, we give insulin, and we can allow people to live normal lives. With type 2 diabetes, we have all kinds of new drugs and old drugs that are available. So there's a lot of treatment options, and we can really get those blood sugars in good control and help people live long, healthy lives.
Right. Yeah, that's great information. That the importance is getting diagnosed and getting managed to try to
Right.
avoid those really deleterious side effects, those bad side effects that can happen in somebody who isn't treated and lets the disease run rampant for a while. All right, we're going to change gears again. So fasten your seatbelt. Let's talk about cortisol. Another thing that we certainly have the ability to assay at Let's Get Checked. Maybe you can tell us a little bit about cortisol, what it does, and how one might use monitoring with that hormone.
Right. So cortisol is a critical hormone made by your adrenal glands. Your adrenal glands, you have 2 of them. They sit right on top of your kidneys, and they make a number of different hormones, including cortisol. Cortisol has a number of important functions. Probably one of its most important functions is that it's a stress hormone. So levels are present in your blood, and they change over the course of the day. They're highest in the morning. But when you're sick or you're stressed, you're running from that bear, or your cortisol levels go up. And that leads to a number of important functions in the short term. If your cortisol levels are up for long term, that can be deleterious and be a problem for your health. Cortisol affects your immune system, it affects inflammation, it has an important effects on blood pressure, so it's a critical hormone. If you don't have cortisol, you can't live. And so adrenal insufficiency is a very serious disease. Often, though, we're worried more about too much cortisol in the body. And there's a syndrome called Cushing syndrome that is excess cortisol production by your adrenal glands, or that either due to adrenal issue or a pituitary issue, because the pituitary gland tells your adrenal glands to make cortisol. Probably the most common cause of too much cortisol in your blood is us, healthcare providers, giving you medications that are steroid hormones like prednisone and others, dexamethasone, to treat other autoimmune diseases, for example, or asthma or emphysema. So that's the most common cause of excess cortisol.
And in your practice, is cortisol something that people should be using to screen for various things? That, I think about what we were just talking about, with some of the other conditions, thyroid conditions or concerns around diabetes, where, not feeling well might be a symptom. A lot of people who you see in your practice, I see my practice, come in and what's wrong? Well, not feeling well. It's very sort of broad, but very real description. Is cortisol one of the things that you implement in your practice to try to get to the bottom of why somebody may not be feeling well?
Absolutely. Now, having said that, cortisol disorders are quite rare. So on one hand, if you don't feel well, you're fatigued, it could be due to not enough cortisol in your body, but it could also be due to too much cortisol in your body. So if someone's losing weight, tired, having nausea, those kind of things, then we think about not enough cortisol, and measuring the cortisol is important there. On the other hand, if someone's tired but they're gaining weight, especially around the midsection, around their face, that's when we start thinking about too much cortisol around. Cortisol is a tricky hormone, though, so if you just measure it in a random time of day, it's sometimes a little difficult to interpret. There are times of day that are better to measure it, and we can also do other dynamic testing of those hormones, but it's often a good place to start.
Yeah, I'm thinking we had at Let's Get Checked, we've had some athletes that have been deploying some cortisol testing to try to help them scale their exercise and their performance. I wasn't highly familiar with its use in that setting. Have you had any experience there in terms of how an athlete might think about using cortisol as a measure of what their performance might be, how to adjust training regimens or diet?
I'll be honest, I have not. I have no experience in that area.
Yeah.
And I'm not aware of any good evidence for that. But, again, I think uh, the world of the elite athlete is a little different, and there's many nuances there. But certainly as a stress hormone, that certainly makes sense that it could be a valuable tool, but it's certainly not commonplace.
Yeah, I think as this individual was using it, as I recall, they were, when their cortisol levels would be very, very high, they would use that as a sign that maybe they had sort of overstretched their system. They would use that as a signal to back off on training, maybe for that day or the next day, increase their rest, things like that. And then when the levels came back down, they would then go hit it hard again. But
Right.
I thought it was an interesting use case. I just didn't know if there was any sort of thing in your world that might suggest how
Right.
that would.
It makes a lot of sense. I certainly don't know of good evidence for it, but it certainly does make sense. I think the other place is, what's the role of cortisol in general health of, and obesity, the general fatigue. There's a lot of controversy over whether a lot of obesity and diabetes is related to low levels of high cortisol. So, modest elevations, and that's a little more controversial. And certainly there's not much in terms of what you could do to treat that, but certainly an interesting area of research.
Okay. Well, I want to be mindful of your time. I thought we'd just try to kind of get into two other ones, which are going to be worthy of further conversations, hopefully in the future for us. But if you could talk a little bit about male hormones, and imbalances in that area. What are the male hormone or hormones, and how could one think about testing and monitoring and looking for those conditions as well?
Right. So the primary male hormone, or male sex hormone is what we would call it, is testosterone. And testosterone has very important um, functions in the body for a man initially early on in life, in normal anatomy development in fetal life. But as you grow, as an infant grows into child, into teenage years, adolescence, testosterone is critical for going through puberty and getting normal male pattern anatomy and other characteristics. And so testosterone is very important. So it's very important for sexual function in that respect. It's very important for muscle strength, and those are the primary drivers. Although we know that people who have very low testosterone, they not only do they have disorders of sexual function, whether it's loss of sexual libido or energy, loss of erectile function normally, they also lose muscle mass, increase fat mass. They have low energy, impacts cognitive function and just general quality of life as well. So it's a very important hormone, does a lot of important things in the body for a man. Women have very low levels of testosterone and probably should never have very high levels of testosterone. There are some roles for measuring it in women, but we'll stick to men for now. I think you have a man who has symptoms of, loss of sexual energy, inability to have erections, has, losing muscle strength, gaining weight, measuring a testosterone level would be very important in that gentleman. Because again, like our other hormone disorders, if we identify a man with low testosterone, we can replace that hormone with testosterone therapy, whether it be a gel, an injection, an implantable medication. So there are options which are very, very, very powerful for those men who have very low levels. There's a more controversial area of kind of this intermediate low testosterone, and there are many, clinics around the communities in the U.S., low T centers, those kind of things. And that in the endocrinologist world is very controversial about what is a normal testosterone. And so, it's a very common for men as they go through aging process, they get into their 50s and 60s to have symptoms that could be consistent with low testosterone. And many men do have relatively low levels. And so the question is, should those be treated or not? Often we find reasons why those testosterone levels are low. So it's important to measure the testosterone. The treatment may not be testosterone therapy. It may be, identify sleep apnea. That's driving the low testosterone, or it's the obesity that's driving the low testosterone. And so let's treat the sleep apnea, let's treat the obesity. So that's important to find those. Sometimes we do find very low testosterone levels that are due to a pituitary disorder or a testicular disorder and so it is important to not just identify low testosterone and treat it, but to try to find out why that man has a low testosterone level and try to identify something that could be treatable.
That's great. All right, with the few remaining minutes we have, and again, these are all warrant further conversations down the road, so I hope you'll agree to do that again in the future.
Absolutely.
Right
now. This is fun.
But if you could mention, and we just talked about men and hormones, let's talk briefly about female hormones. I know this is probably a topic that could have its own multi-day conversations, but a little about what are female hormones and some of the impacts there.
Right. So the women have a much more complicated sexual hormone physiology, and therefore it gets more complicated to diagnose disorders as well. So the primary sex steroid in women is estrogen. We generally measure it as estradiol in a blood test. That's made by your ovaries. That's controlled primarily, again, by the pituitary gland through normal pulsing of hormones called LH, luteinizing hormone, and FSH, follicle stimulating hormone. And so that is a very key hormone that is important, again, in the normal sexual development of a woman, but also important in their regular menstrual cycles, important for pregnancy. And then obviously when we get into older age women, loss of the hormone estrogen is when women go through menopause and the whole pathophysiology associated with low estrogen in those women. But women also make other hormones that are important in this whole uh, uh, pathway, and that's progesterone as being the most important one there again. And so progesterone levels change through the menstrual cycle and have very much to do with having a menstrual period. And so it's this interplay between estrogen and progesterone that are critical for normal menstrual cycles, normal ovulation and fertility, and so women can often have abnormalities in their menstrual cycles, and that requires potentially measuring these hormones and others that hormones that come from the pituitary gland as well.
And are there specific instances or conditions that one might look at, going back to talking about symptoms a little bit, where a woman might suspect that she's a little off kilter there on some of those hormones? Are there things they can look for?
Yeah, I mean, I think for women, it's sometimes you can pick up changes earlier because what happens is their menstrual cycles are disrupted. So all of a sudden there's a change. Obviously, we want to rule out pregnancy as the #1 cause of that. But if a woman misses a period or misses 2 or starts having irregular periods when they had normal and regular periods before, that's a clear sign that something's going on. And that evaluation should be taken forth. There's also the loss of estrogen. So, typically the most common age for a woman to go through menopause is around 50, but it's anywhere between, 40 to 60. And the common symptoms are, again, loss of your menstrual cycles. We call that amenorrhea. But often symptoms are hot flashes, classic symptom that women get when they lose estrogen. It could also be changes in mood, changes in how you put on body fat, changing distribution, cognitive function changes. So many things can change as you lose estrogen through menopause. But you can go through menopause early, and there are disorders that you would want to identify early in younger women who lose their estrogen.
Great. As I said earlier, I think probably a lot of these topics could each be their own in and of themselves, and maybe we'll make that happen here in the coming days, weeks, and months. I can't thank you enough, Marc, for not only for this, but again, your participation on our advisory board. Just thank you for your generous time and all of your great insight. So we'll let you sign off, but any parting thoughts or?
Yeah, I mean, I think thank you for the invitation to participate. This is a lot of fun and very important. Again, I think to reiterate that when things aren't well, we can often diagnose an issue, and with the endocrine system, the nice thing is often it's not always straightforward, but we can often find a diagnosis if it's there, and if it's not there, then we look for other things, and that's the thing that's I think really important. If you think you have hypothyroidism, but the tests are normal, well, it's not hypothyroidism. Let's find. It doesn't mean there's nothing wrong with you. There's something wrong. We need to figure out what that is. But if we do find an endocrine disorder, almost always they're treatable, and so we don't want to miss those disorders because they can be treated, and that can have significant impact on your life and your health.
Terrific. It's all great advice and great information. Thank you again. Appreciate it, and we'll do more of this for sure.
All right, great. Well, have a great rest of your day.
You too. Thanks.
All right.